there is nothing saying that you have to wait until a certain time to start making your birth plan. Obviously, after birth, it might be a little late to make a birth plan, but it doesn't hurt if you're if you're in the midst of pregnancy to make that birth plan. I recommend that folks are really thinking about their birth plan, at least ready to start creating that birth plan around week 20 when you get your anatomy scan. That's a great time because chances are around the time you get your anatomy scan, you'll probably get an invitation to go and tour the unit, the labor and delivery unit that you might be delivering at. And when you tour that unit, you have an unprecedented opportunity to gather additional information, data, context that can go into that can be incorporated into your birth plan on a granular level. So let's talk a little bit about the anatomy of your birth plan. So, what your birth plan will cover, and this is going to be pretty brief, but it is labor support. First and foremost, labor support. It's very important for you to know, and this is dependent not just on the birth center or the hospital unit that you're at, but this can vary down to the provider. It might be just the provider's decision that determines how much, what type of birth support you can have. If it is not in policy, that opens it up to more of a conversation, not just an edict. Okay. So, who do you want in the room? Do you want music? Would you like lights? Would you like movement? Do you want a yoga ball? What kind of labor support is available to you? One thing I love to talk with people about is when you're touring that unit, that is a great time to learn about whether or not the unit is using a hospitalist system, whether or not your provider is has privileges at that hospital or birthing center, whether or not certain tools and assists are available to you. For example, you might want a sling, you might want a yoga ball, you might want red light, you might want blue light. Knowing these things in advance, or knowing in advance what your options are, help you fill in the blanks and fill in portions of your birth plan. And that birth plan goes from being generic to more realistic and aligned with what your actual options are so that you have more control and agency there. Pain management. Maybe you are going to want an epidural. Maybe you're on the fence on if you want an epidural, maybe IV meds. Maybe you want to try natural coping first. Have an idea in your head. Start thinking about what that is like for you. When it comes to pain management, I typically hear the following. Folks will, because oftentimes deliveries are scheduled. I mean, deliveries do come in, folks do come into the hospital in labor, but oftentimes what will happen is when a person is in labor, they're notified that the anesthesiologist happens to be on the floor. But here's the thing, right? Just because the anesthesiologist is on the floor right now, that doesn't mean that your only chance for an epidural is right now when the anesthesiologist is on the floor. The anesthesiologist can always be paged and asked to come in. If the anesthesiologist is on the floor, it will be quicker for you to receive that epidural at that point because right in front of your house. Get me? It takes time for the anesthesiologist to circle back to that unit. Even if they know you're there, they might be caring for other patients in other areas of the hospital as well. So if you do wait and you decide, okay, I am going to labor here, just know that, and I'm not trying to say you should have an epidural or you shouldn't. That is not my place. That is with you. But I am saying that if you ask for an epidural and that anesthesiologist is not on the unit, or that anesthesiologist is on the unit and caring for another patient at that time, it might take some time until you are able to get an epidural. And that opportunity might end up being missed. So when the nurse is stepping into the room and they're letting you know, hey, the anesthesiologist is here. Would you like an epidural? Please don't assume that that nurse is trying to be pushy with you. They might be. I'm not there. Don't assume that they're trying to push an epidural on you. They know that this is your choice, right? But as far as the inner workings of the hospital and the inner workings of the unit, they're being mindful of the time that that would typically take for you to have an epidural if the ice cream truck leaves from in front of your house, if that makes sense. So yes, knowing that. Another thing is folks don't typically know about pain management options that they have. Like typically folks are thinking about, okay, I'm going to be going into labor. I know labor is going to be painful, but very few mothers are educated in advance to know the impact that common medications have on pregnancy, have on labor intensity, and on the intensity of those contractions. For example, Pitocin. I don't know if you've heard the word Pitocin before. Pitocin is a synthetic form of oxytocin. What oxytocin does is it helps contract that uterus, right? So that you can get the baby out. It helps you contract so you can get the baby out. Another thing, and this hormone, oxytocin, the actual intrinsic form, and Pitocin, the synthetic form, is your best friend postpartum, is your best friend in that early 48 hour, actually more than the 48-hour period, but especially in that 48-hour period, because after the baby comes out, you still want your uterus to continue contracting so that eventually it goes back to the size that it was pre-pregnancy. That is why it hurts so bad the first few times that you breastfeed, because as you're lactating and expelling that colostrum or expelling that milk, it also releases your intrinsic oxytocin and makes your uterus contract. So you will literally be there nursing your baby, and if you're breastfeeding, nursing or pumping, and you will feel your uterus cramping up and like contracting. That's a good thing. That's a very good thing. But what I'm saying is Pitocin causes intensity of your contraction to increase. So, in my experience, and in a lot of experiences, really, a mom will come in and say, okay, I want to do this natural. I want to do this without an epidural. And everyone's like, okay, we're going to give you Pitocin. And they're like, okay, because they don't know. They don't know that when the Pitocin hits, those contractions can turn into the Incredible Hulk. Let me tell you. Pitocin is works by titration as well. So it's not like when you have Pitocin on board, which is given IV, the Pitocin is on or off completely. It can be on or off, but it slides like it's titrated. So you can have very little bit of Pitocin consistently or larger amounts of Pitocin consistently. I'm going to talk more about Pitocin later on, but I wanted to touch on it during pain management because that is a very important part of your birth plan to consider whether or not you anticipate using Pitocin, or like for example, if you're going to be induced, you will be on Pitocin because that's how you get labor started and that's how you get labor to progress. Knowing that empowers you to incorporate that context into your birth plan. Moving on, interventions. This touches on Pitocin as well. What are your wishes? around certain common interventions. Medication administration counts as an intervention, right? And Pitocin is a medication. So Pitocin is an intervention that you get to choose as the patient whether or not you agree with, you disagree with. It's your thoughts and feelings on whether or not Pitocin is started and how that Pitocin is going to be used. So what are your wishes? Best case scenario, again, things happen, we get it. Okay. But best case scenario, what what are your wishes around things like Pitocin? What are your thoughts and feelings about things like an episiotomy or having your water broken? An episiotomy essentially is when you are literally cut to make the area larger so that it's easier for the baby to slip out. Having your water broken, that's essentially like that. That's essentially they take a little hook, and they go, it's almost like a little crochet thing, and they go pop, your waters go, and that kind of helps get labor off to the races, on and popping type of thing. These things can happen naturally, right? Like getting labor started, these things can happen naturally. So anyway, back to the interventions. So these are interventions, and these interventions exist for a reason. There are clinical reasons why a person would be on Pitocin to get the labor going. There are clinical reasons why your Pitocin will be cranked up, and that is to get the labor going or to progress your labor. There might be an emergency. It needs to be a clinical reason why you do that, because every intervention has its risks, benefits, and reasons behind it. But yeah, there are valid reasons for using Pitocin. I am not saying Pitocin is evil by any means. I'm just letting you know that that use of Pitocin is an intervention, and you are the leader of your team. So it's very good for you to know these things. Use of an episiotomy. I don't want you to be in the situation where you are learning about episiotomy and then consenting, making. Here's the thing. This is a situation I don't want you in. I don't want you to be in the situation where you're learning about the episiotomy, you're laboring and in pain, you are exhausted and stressed out, and having to give informed consent on if you're going to have episiotomy or not. That is why I'm sharing with you and I'm telling you about what episiotomy is, right? Inviting you to learn more about episiotomies so that if you are offered a episiotomy, you can go from that point, from that platform. You don't have to start from down here. You can start from here with your understanding and be able to make more of an informed decision that maintains your agency. So anyway, so that's episiotomy. And then having your water broken, same thing. There are clinical indications for having your water broken, and that is for you to discuss with your health team. But what I am saying here is a lot of these interventions, these practices, again, they have their medical time and place. Okay. But what I'm seeing a lot of is operationalizing of a lot of these practices. And so these practices might be used whether or not there's a clinical indication that they need to be used, a clinical indication of necessity. Do you see what I'm saying? Like that's the difference between having things done to you just because that's the process that this provider typically goes through and this is how they like their deliveries and their labors to go on time and whatnot, versus a discussion with you and learning and collaborating like a team for your best outcomes. And then newborn care, right? Newborn care, skin to skin, incredible. You have options like delayed cord clamping. When that baby comes out, that baby will be attached to their placenta by their umbilical cord, that cute little umbilical cord. And when the placenta comes out, It doesn't mean that the placenta's job is done immediately once it magically is expelled. No, that placenta will continue to contract and expel nutrients and circulation. You might decide that you want that placenta to finish contracting before the cord is cut, disconnecting the child from the placenta. That might be something you would like. There are other options for the placenta. The cord, you might want that blood cord banked. You might want those stem cells to be banked and stored for your child in the future. You might want the placenta to be encapsulated or preserved in some sort of way. You might want to take the placenta home. These are all things for you to think about, to consider, so that you can have a plan in place so that folks know what your expectations are. Because the last thing we want to happen is for that placenta to go into surgical waste immediately. And you're just like, wait, once the cord's cut, once the placenta is no longer with you, just things like that to understand. And of course, feeding preferences. Have an idea ahead of time on what your feeding preferences are. Again, I am not here to tell you that you have to exclusively breastfeed. I'm not here to tell you that if you said, I plan on using formula, that you can't breastfeed. No, plans can change, but step in empowered with an idea of what you wanted to happen and how you want things to go. And then when you know how you want things to go, you are able to lead accordingly. So, newborn care, skin to skin, delayed cord clamping, feeding preferences. Also, like, where do you want, do you I like to have the baby in the room with me, next to me. Like, you're doing footprints, you don't have to take the baby away for footprints. Just saying. So, as you can see, there's quite a bit that goes into this. What I am not trying to do is have you create a binding contract and assume that everything's going to go perfectly according to that. But what I want to do is empower you so that when you do go into labor, you're able to, you have more confidence and you're able to speak for yourself and maintain your agency and lead accordingly. It really sets the stage. It really sets the stage. I do have a recommendation when it comes to these birth plans too. It does not hurt to use your portal, your health portal, right? And this is how I would use it in order to send a signal and in order to make sure that folks have eyes on my birth plan. In a lot of these portals, you're able to message your provider or message a member of your care team or make an appointment, whatever. You can even do it in your registration. There's typically a place where you can add a file. Typically, it will allow like a PDF file or something like that. What I recommend is you have your birth plan, right? It's a working document, but you still have your birth plan. You've done your tour, so you have some of those nuanced stuff, some more valuable context incorporated in that birth plan. I send that birth plan in the chart or in the portal. And so when I arrive, what can happen is I can ask a member of the staff, the nurse, whomever, hey, my birth plan is in this message. Please pull it up. Please print it out and bring it to me, and you can have a copy as well. I'm not saying that I don't have a printer at home. Obviously, I'm going to have a copy of my own birth plan in my bag, like for sure. Yeah. But what that does is, one, it confirms that a member of your care team that's caring for you has seen your birth plan because you are asking them to retrieve it, asking them to put it, to bring it to you and put it in your hand. Just making that request is huge because guess what? That means that they go in, they They see your birth plan, they print it out, and they hand it to you because you've asked. That means that they see it, they bring it to you. You've also said, hey, this is your copy as well. Okay. That is your opportunity with that member of staff if you have time. Again, this is assuming you have time, but that is your opportunity at that time. You have a copy, they have a copy. That is your opportunity to get that person on board with you, go through the birth plan together with a member of the care team so that if you end up loopy or whatever, at least another member of the care team has gone through your birth plan with you at the bedside. Do you see what I'm saying? So, yes, I think that's very, very important. And I love that strategy. Prolong. This is more to have a conversation than a specific number. And you're going to see why in a minute. There are indications for prolonged labor. Okay. So, prolonged labor might lead to an episiotomy. Prolonged labor might lead to having your waters broken. Prolonged labor might lead to starting Pitocin or increasing Pitocin. What you need to know is what is considered a prolonged labor for the provider whose jurisdiction you are under, right? And what or how is prolonged labor addressed typically? Because at that point, if you were on the brink of prolonged labor, okay, based off of the opinion, the medical professional opinion of that provider, it's important for you in advance to have discussions about what you're okay with them doing, what you're okay with them not doing, or so on and so forth, right? And it's also important to know like the rationale behind all interventions, but the rationale behind the intervention as well. Like, is this a prolonged labor and are you cranking up my Pitocin or you're giving me an episiotomy because you're on a schedule? Or is there something going on with my clinical signs? Is there something going on with the clinical signs of the baby or babies, that's concerning you? Like, these things are very, very, very important to know. And that is so that you don't have that sensation, that feeling, that terrible experience of interventions just blindly being applied to you. There's that. And then there are questions that I love talking about, like, why was my induction date chosen? If the induction date that you're given is before 40 weeks, you need to know the reasoning behind that because the person that chooses the induction date is you because you are the leader of the healthcare team, not the other way around. So, have this conversation with your provider and have this conversation with the provider early. The provider needs to know in advance how you feel about in your birth plan. I will put this if you're doing patient rounds, make sure that you do those rounds in my room or make sure that when you're rounding on me that it's in my room unless there's a reason why not. Like, for example, if you're a patient and you're on isolation precautions, they're not going to do that because that would introduce more people into a room and that becomes more of an infection risk for other member or other people on the unit. We get that. But I'm talking about like in the best case scenario, if the stars align, they should know that your expectation is evidence-based practice. They should know that your expectation is the gold standard, which is bedside rounding and bedside change of shift report. I said what I said, and I'm not going to unsay it. And then, of course, keep your birth plan close. Next, I want to share with you guys a little bit about consent is not a piece of paper. Consent is a conversation. Obviously, you're going to sign a piece of paper for them to bill your insurance, for them to even touch you. You're going to sign a HIPAA disclosure, and you're going to receive a HIPAA privacy notice and all of that. But I'm talking about consenting for certain interventions. An intervention includes, and you heard this earlier, Pitocin, right? Pitocin is used to speed up labor, but it can also make contractions stronger and more difficult to manage. So always ask about the risks, the benefits, and the alternatives. And there are alternatives to Pitocin. Episiotomy sometimes is recommended, but tearing naturally often heals better than being cut. So ask if it is actually necessary. And that is infection control. Infection control, right? One of the leading causes of morbidity in the postpartum and pregnancy recovery is infection. I'm just going to leave it there. Okay. And then, of course, breaking your water, it can sometimes speed things up, but it also raises the risk of infection. So if it is not clinically indicated, because there are clinical reasons why someone would recommend breaking your water, breaking that membrane, but if it's not for a clinical reason, ask why. What I'm trying to say is these interventions should not be applied to you, done at you without your consent, right? They shouldn't be. And a lot of times these interventions happen automatically. These things are typically done routinely to help optimize the flow of the unit, to help with operations. So it's very important for you to know and maybe to agree or disagree to, right? If you know that that intervention is not for a clinical reason and it is to help optimize operations of the unit and to help optimize operations and the schedule of the provider, then you might say, I prefer that you not break my water, or I I decline an episiotomy. But if there's a medical reason why, that changes everything. But what I'm just trying to empower y'all. I'm just trying to empower you. Anyway, here's some scripts for you to practice. Write these down. Is this urgent, or do I have time to think? Another one that you should practice out loud is, what are the risks, the benefits, and the alternatives? How does this fit into my plan? So, how does the episiotomy fit into my plan? Do you see what I'm saying? You see how that sounds? The reason I encourage you to practice this and to practice this out loud is when we are in that high pressure situation, when we're in an environment that is not natively ours, the hospital and a hospital room clearly is not home. Clearly, it's not my domain, right? It is not as easy to find our voice in those rooms unless we practice beforehand. So you might be in the shower one day going, how does this fit into my plan? Someone's gonna be like, what? What do you say? But yeah, you might be driving, practice. How does this fit into my plan? You know what I mean? Like, practice these things, think these things through. They're rehearsing, they're preparing for it. That has everything to do with the birth plan. The birth plan is you setting the stage, going through it. And sometimes when you're going through it, your version of going through it is literally saying certain things out loud. So you know how you sound when you say it. Is this urgent? Do I have time to think? What are the risks, benefits, and alternatives to Pitocin right now? And how does Pitocin fit into my plan? Notice I said my plan. So remember, Consenting to care. Consenting to care is not the end of the conversation, right? And then how to confirm that all the kids are out of the classroom, how to make sure that all the kids were accounted for, that little Bobby wasn't still in the bathroom. And you know what I mean? Like all of that happens in a fire drill. Have fire drills for your emergency situations. Have a fire drill plan for your emergency situation. Okay. Because guess what? You might be high flying as a kite, happy on endorphins after pregnancy, especially those first few hours. That might be you. It wasn't me, but it might be you. And that's great. But it would be silly not to plan for a rainy day when mentally we might be struggling. And if we enter into crisis, that is not the time to figure out where we're going to go when the fire alarm goes off.